All right, good afternoon, good evening, everybody. Today is the 7th session of our Prayojana series, Liberation of Knowledge on COVID-19. And since we are going into 5-6 months of this pandemic, we want to continue with this liberation of knowledge and sharing it with everybody. Today, because we had the hurricane tropical storm last week, a lot of people lost power and a lot of things were happening, so we didn't have as much time to prepare well. So we're going to work with what we have. That's why you're seeing my picture here. I don't usually come in to be the subject matter expertise, and but we have Dr. Joyce Grossman, who is infectious disease, internal medicine, and pediatrics in board certification as a medical doctor, and 3 additional masters in immunology, genetics, cell biology, biochemistry. She has done research in Rockefeller University and also was managing large millions of population at multiple states and breaking through silos. And she now serves as the Chief of Population Health and Research at GlobeX Health. And you can see did my edit, so you probably can see a little bit of Dr. Ortel's name because I had to do this over. The CEO and Chief Innovation Officer for GlobeX Health, but I just have a lot of experience in dealing with complex blending tech and revenue, finance, managed care, and clinical. And Dr. Adesola Okasanya, who is a family medicine physician, virtual care, and COVID-19 frontline. She's also an expert in bridging the gap in post-acute care and digital health, and she is part of the team inside GlobeX Health and leading that area. Today's session, there's a disclaimer. This is really for information only and sharing knowledge. There is no medical advice. You need to take into consideration what is going on with each person and reach out to your own physicians or other areas for medical advice. There are a lot of COVID resources. These are the ones that we recommend because anything related to COVID-19, it's shifting. It is not 100% accurate at any time. We're going to cover today, inside the paradoxes of COVID, some of the medical and genetics perspective, since Dr. Grossman has a genomics background. We are focusing today on testing, PPE, especially on a mask, post-COVID syndrome, and vaccine updates. The reason is because that's been like common issue that we seem to run into, and thought this will be an area that will be helpful to share some shared knowledge base. Some of the stats, and then we're going to talk about the testing, PPE, post-COVID syndrome, and what's new in vaccine. This is a slide we shared in the past. If you are going out and there's a level of risk on where you go, and this is a information put out by the Texas Medical Board. The lowest risk being like opening your mail, pumping gasoline, the highest risk going to a bar and eating at a buffet, working out at the gym. Yes, working out at gym is a high risk. Latest COVID numbers, this is from Johns Hopkins. It's as of 4 o'clock this afternoon. We have total globally 20,000 cases, 20 million cases, and US leading at 5 million, over 5 million, Brazil being the number 2 at 3 million, and India being 2 million, and Russia the next highest at 895,000. Global deaths are total at 738,000, so we're close to 750,000. The US leading at 164,000 in deaths, with Brazil being second at 101 deaths and 101,000 deaths. And next is Mexico at 53. It's interesting with Russia's numbers being high, their death rates are not as high. It could be a potential area we need to take into consideration. It's possible that the reporting of death is not being as accurate as other areas of death, area being reported. This is the data from Same similar sources, same things are sourced, but it is put together by the COVID project by the Atlantic. So you can see the number of new tests that's just on August 11th, Tuesday, of the 56 areas, states, or that includes the territories tracked. There were total 5 million positive total. It's cumulative, so 739,000 new tests total. So, and there were 58 million negative, COVID negatives. And there are 48,000 in hospital right now. So just wanted to know. There's another area that we were going to be bringing up today. Dr. Okasanya, do you want to kind of start talking about the racial disparity in this space, especially for COVID? Because that's one of the things, especially in African American population and Hispanic and Asian and Native Americans. Let me just make sure that she's able to come on. Dr. Okasanya, are you able to talk? And let me see, because I made you panelist. So let's talk about this. This is a big deal. You know, we are seeing a lot more African Americans dying from COVID, then more Hispanic, and then, so there's a tremendous amount of racial disparity going on here.
All right, I could sort of give you some reasons why that's happening. I mean, of course, number one, it's a devastated population, all right? There are fewer health centers in their areas. There are fewer doctors in their areas. So they're not really getting, they're not eating as well, and they're not getting as good care as people in, you know, in areas where there are more resources. They also don't have the luxury of working from home. So they're not able to distance themselves. They're frontline workers. They're delivering food. They're doing mass transit. And we know that viral load really leads to getting the illness, and they are in environments where there's a high viral load. So their environment just makes them more susceptible. There also, of course, may be genetic reasons for their susceptibility. I mean, they may have more ACE2 receptors. You know, that may be, you know, a genetic component of this. But, I mean, the fact that their environment is not conducive to being able to get either avoidance or better care leads to more susceptibility. They also have higher levels of obesity, and obesity is a very strong risk factor for serious illness with this virus. They have more diabetes. Diabetes is a risk factor for infection with this virus. They have COPD, which makes them more susceptible. They have heart disease. And again, they have less resources to get these underlying illnesses treated. So that is another reason why their levels are so, you know, high and are higher than more affluent regions in the United States.
So, Dr. Okasanya, do you have anything to contribute?
Oh yeah, finally Zoom allowed to talk. Joy.
Okay, good.
Yeah, so I mean, definitely this is definitely been highlighted a couple of times over the past couple of weeks, and I think I would just like to echo what Dr. Grossman kind of already mentioned. Yes, you know, I guess we've noticed, you know, we've kind of long noticed that the care that more minorities, Black, Hispanic, Native Americans actually receive do tend to be of a lower level. And, you know, I think they're just multi-factors for that, some of which of, yes, you know, there's the problem of access there's a problem of, you know, availability and, you know, partly maybe even also education. But I think also too that there is actually systemic problems that exist in our health system as well that does hinder a lot of these people getting, I guess, parallel care as compared to the rest of the population. So I think these are things that we definitely should look into because, of course, you know, at the end of the day, it does affect everybody else down the line. So it's definitely something we should really kind of look into, see how we can really kind of correct for that in many ways, and just really kind of being a little more, I guess, a little more hands-on on our minority patients, making sure we're really making sure that they're really getting the access they need, the accessibility, and the healthcare they really need. You know, because I think this is a bit, you know, we are seeing this, and it is showing clearly that our system is not working for these people.
Yeah, I think the best test, this is Dr. Halasa, the best test to really screen vulnerable people is doing the endothelial function test. And I think we need to start doing it. That gives us, you know, help to put the resources, direct resources to those people who are vulnerable. So that's my comment here.
Dr. Ortel, I see now that you were trying to make a comment, and I'm so sorry I didn't see that until now. So please feel free to talk, because I did change you to be able to talk. Let me just see. You should be able to talk. Are you able to unmute and talk?
She might be having the same problem with me.
Yeah.
I can hear you.
Yes, it kicked me out and I had to come back in.
Come back in.
Okay, so we are all having similar issues with Zoom. All right, Dr. Ortel, we can hear you. Feel free to talk.
Well, I just wanted to reiterate what had already been said, that, you know, some of this with the Black and Hispanic groups is the increased density of the ACE2 receptors. And we had talked about that several weeks ago, and that is quite a big risk factor for them. I think, but I certainly agree with the fact that they have a higher rate of comorbidities and less access to healthcare. Plus, they may be in occupations where they're more on the front line.
I saved one of your slides. This is the information that you had posted about, you know, the populations, and especially on the race disparity. This was a slide that I kind of saved from one of the presentations that Dr. Ortel did in the past session, that shows, you know, from the genomic side, the higher propensity for, you know, higher risk for the different type of race.
Well, other mechanism that leads to increase in ACE2 receptor. Now, everybody thinks that ACE2 receptor is a bad thing. ACE2 receptor is an enzyme, which is very important. It's an antioxidant enzyme, anti-inflammatory enzyme. And this ACE2 receptor, it increases in patients who are in oxidative stress. It's a compensatory mechanism to neutralize those free radicals, or the body who is being sick with oxidative stress. Compensation for that, the body starts building more of ACE2 receptor to kind of healing itself, in other words. So those people who are hypertension, as Dr. said, hypertension, diabetes, and obesity, they already have higher ACE2 receptor than the healthy people. In addition, they will have abnormality of function tests, which put them the risk of both exposing to the virus easily and also get the cytokine storm and the complication of COVID-19. Very
good. So that makes sense. One of the latest publication from JAMA identified surveyed in New York during the major COVID time frame in March, April into May, the risk factors and what the home health aid workers and nurses aides went through, how much of a, they are also frontline workers and they are invisible. They are not identified. They don't talk about. And, some of the things that had happened to them and some of the post-traumatic stress syndrome that you're starting to see in that population. This happens with the home health aid workers, the nurses, obviously doctors, and others too. But this type, they are mainly minorities, and you will see a lot more home health aid workers as minorities. And if you are in a minority geographic area, and they go into hospitals or into homes that is also occupied by minority, that thing that just perpetuates the situation where you're at higher risk, you're also taking care of higher risk population, and you may not have as many resources and less of a knowledge to how to source certain things or get the knowledge. So that was the latest from JAMA. Dr. Grossman, do you have anything else to add to that? Because I know you had a later a JAMA article that I didn't get a chance to put in here that you wanted to mention.
In terms of the, you wanted me to discuss the acute and post-acute symptoms of COVID-19?
I guess we can discuss it here, yes.
Okay, all right. Just wanted to make sure I'm not jumping the gun here. There is a new article from JAMA, August 11th, volume 1324, number 6, and it's from Italy. So Italy had a very similar type of virus like we did on the East Coast, and now really it's throughout the United States. And basically, they said that in Italy, a large proportion of the patients with corona disease presented with symptoms, like 71% of them, like cough, fever, dyspnea, musculoskeletal symptoms, myalgia, joint pain, fatigue, gastrointestinal symptoms, and anosmia and dysgeusia, which, loss of taste and smell. And what they looked at is after these patients recovered, what symptoms were they most commonly complaining of? The most common, of course, was fatigue and dyspnea. But they found that patients who had joint pain as a presenting symptom also had joint pain as in follow-up, as a post-viral syndrome. They also continued, many of them, to have chest pain, cough. Some of them had continued loss of smell. They had dry mouth, rhinitis. A small percentage, and these are had continuing red eyes, loss of taste, headache, sputum production, lack of appetite, sore throat, vertigo, myalgia, and diarrhea. So we're talking about really a varied number of, symptoms after you're supposedly well. And now now post-viral symptoms are not unusual. I had patients, and I remember many of them had, symptoms that lasted, but it wasn't as large a percentage of them as patients with this virus. It seems that 87.4% in this Italian study reported persistence of at least one symptom. It was particularly fatigue and dyspnea, but I've seen pictures of a lot of these people, and they really have severe dyspnea, and it's hard to do things with fatigue. I mean, if you remember chronic fatigue syndrome, that is a very disabling condition, and many of these people have symptoms like that, and 87.4% have these types of continuing symptoms. So basically, this is a problem. Now, they say their study did not have information on symptom history before they got sick with this illness. And so we don't really know how many people had these, these complaints and maybe had very severe complaints. And this is also a single center study, and the patients were relatively small. There was no control group. And, basically, they're saying patients with community-acquired pneumonia can also have persistent symptoms. So, you know, they're not saying this is exclusive to this virus, but what they're trying to point out is that this virus is leaving in its wake a lot of patients who may be disabled for quite a long time, and it's a problem that really has to be, you know, studied more, you know, intensely. So I thought it was a very interesting little, you know, more of a letter than a real study. And it's very new. So, and again, it's from Italy.
Perfect. Yeah, I mean, that is, and they had a Chinese study also on this that was published. Same story. They're looking at people post-COVID, and they're finding them with all these issues that, including, and you know, the most common one is mental fog and the chronic fatigue syndrome. Those are the two. And then the depression, PTSD, and anxiety, the mental health side. The concern is, in, you know, even now in other parts of the country and other parts of the world, frontline workers, the healthcare workers are being thrown at this, and they do really need to, you know, we really need to address that. And I don't think, you know, everybody's trying to put out the fire, so there is no way to kind of take that into consideration and start acting on it. So our hope is having this kind of conversation and bringing this out to light a bit more. It would be, you know, there will be more awareness to it, and we'll be able to have some sort of means to address this down the line.
You know, I agree, Juby, and I think in terms of the, quote, mental symptoms, we're not really sure how many of them are neurological, because remember, this virus goes into a receptor, like in the nose. It's very, very close to the brain. And maybe some of these symptoms are really neurological. So patients that we think, well, they have, you know, post-traumatic stress may have a real neurological condition. The patients that have memory, you know, problems may actually have a mild form of dementia.
Yeah.
You know, we're not really sure what is neurological in terms of lasting symptoms, and that may be a big problem down the road.
Yep. So I agree, and we still have to wait and see on this area, but as people who had to watch through and live through 9/11, was exposed to it and had to deal with all the post 9/11 consequences, while we are managing our own patient population who is also 9/11 exposed. We had those years and years of watching until I think it's 7 or 8 years into it is when things started to lay down. Oh, there is something called post 9/11 syndrome or dust exposure. And then more and more people are being identified. And our hope is that in this process, that particular piece is done earlier within the COVID area. Because, you know, and it's still in the midst, so it all takes knowledge, allocation of resources, and early identification, early intervention. That would mean we can reduce the decline and additional complications that would happen. And mostly patients and people, they do not know what's going on. They're just going to come to providers or physicians with symptoms. Dr. Otel, I know, yeah, there are some comments coming through, and I maybe I will start reading some of them because I didn't realize it was there. So Dr. Halash mentioned about the ACE2 in the brain. William Robinson mentioned about the COVID-19 may impact and add to the already present mental health crisis. Yes, it is a huge problem. And who are the ones who will not seek treatments and identify? The minorities, the ones who have socially determinants of health challenges, including money and resources. And the other ones being on the number one, healthcare workers. Yes, nurses and doctors they do not seek help as much as others. So we are the other ones who needs to be kind of proactively prompted and put it, have a process created so that it's not as difficult on doing this. And I see that Dr. Otel mentioned something. Do you want to talk it out loud, Dr. Otel? Because rather than me reading whatever you were saying, it would be easier.
Yes, we were talking about neurological sequelae from COVID-19, and there's been a lot of talk about this post-viral syndrome, and one of the problems is the lymphatic drainage, so that the fluid coming out of the brain is not draining, and a lot of people are actually having congestion, and so that needs to be taken care of with lymph massage. So you're getting different areas of the brain are becoming swollen because the cytokines can't be released. So these are all adding to some of the neurological problems that we're seeing, but we're definitely seeing it's being reported that there's an increase in Alzheimer's. We talked about the mood disorders, and all those things are related to the central nervous system not being able to clear all these toxic substances.
Dr. Okasanya, would you like to share some of your first-hand experience in this area?
I think it's just been a challenge with this pandemic altogether. And yes, PPE has continued to be a challenge. I know right now in places like in New Jersey, New York, where we've kind of stemmed a bit the pandemic a little bit. We've had less COVID numbers, and we have less COVID in the hospital. But again, PPE tends to be a problem, and there is definitely emphasis on trying to save PPE. I know right now, like a lot of physicians, they don't actually give N95s to, because now they're testing everyone. The rationale is like, well, we test everybody before they came in, so hopefully they don't have COVID now, and so everybody's just kind of like wearing surgical masks now, which of course has some efficacy, but we all know that N95s are really the gold standard. So so these are things that are happening, and then also people are actually encouraged to kind of preserve their masks and reuse, and it comes with a lot of issues with that as well.
What about the post-COVID syndrome that you're seeing in patients who recovered from COVID-19, Dr. Okasanya?
And I work as a hospitalist, so I don't think I've seen a lot of post-COVID syndrome. I guess one being because usually it's not as severe enough to kind of bring them to the hospital. I feel I've heard of it more in the outpatient setting, but I haven't really had someone who really kind of came in with that syndrome specifically to the hospital. I've had a few patients who I know we've treated with COVID-19 earlier in the year, and then they came back for one thing or the other. I don't think we really kind of identified anything that was clearly like a syndrome. I mean, sometimes people might say maybe they're a little more tired or fatigued, and it's hard to kind of really say. I think though, but yes, I've heard a lot more reports within the outpatient setting, and I mean, which is probably more appropriate because usually these are things that maybe would not take you to the emergency room, so to speak, but it would probably take you to your primary care doctor.
Yep, you're right.
Yeah, I agree.
Yeah. So, Dr. Grossman, do you want to talk about, without revealing the PHI area, talk about our first patient interaction somewhere in March 18 or 20th when Dr. A's sister went into the hospital in New York City, ended up in the ICU, vented, and that's when we, as someone who didn't want to get involved in this area, not because of that, we just thought there were a lot of people who were more capable to do this, ended up having to deal with ICU, COVID-19, early, March 24th was when the plasma serum was FDA, the policy came in, but we were trying to deal with it even before that. So because that patient from the ICU, I think 3 weeks in the ICU or 4 weeks in the ICU and went on remdesivir and other things, survived, now have post-COVID. So that's from March to now. So
yeah, well, I mean, she was very, very severely affected. This is a girl who runs her own business and then didn't feel well one day and said, well, I'm not feeling well. Then she became short of breath, but she had no known lung problems. And she said, I remember she called her brother, who's a doctor, and said, I'm so short of breath, I think I'm going to the emergency room. At which point, in the emergency room, they had to intubate her. And she spent about 10 days on a ventilator because basically the girl could not breathe. And they did put her on the remdesivir. But, at the time, I mean, it didn't appear really to be making that much of a difference, except that she did end up being extubated after 10 days. And she has, in terms of her respiratory symptoms, in terms of her viral symptoms, I mean, she's been stable. I mean, she developed a DVT, but that's hard to say whether that was from the virus or just for a 50-year-old woman being, intubated for 10 days and not really being able to walk. I mean, it's difficult, but she did have a DVT as a complication. At this point now, what she's left with is really, more post-traumatic stress, whether or not that's from just being in an ICU on a ventilator, because when I did ICU work, I would find many patients did have post-traumatic stress after being taken off a ventilator. There was a fear they'd have to go back on the ventilator. They found the whole experience very, very difficult. And in her case, I mean, she was on a ventilator and was totally, not conscious because the ventilator was breathing for her. But there are patients, especially as they're getting better, who are more awake. And the extubation is very, very difficult because basically when they disconnect you from the ventilator, it's like you're breathing through a straw. It's not easy. So it does leave people with this impending feeling, of disaster. But I mean, so far, at least physically, she's been doing, okay. But I mean, this is also a problem that people who do okay are left with.
So she's going back to her restaurant now, but she has fatigue and mental fog additional, which, at this point, there was a, 50, even 80% chance she wasn't going to survive. We were all concerned at that point. So to be honest, we're just thankful that she is back to work and doing what she likes.
Oh, no. I mean, to me, she's a miracle story. I mean, unfortunately, I've no patients who have not done as well. And they were patients that appeared to be doing well. I mean, they were put on high flow oxygen, and wow, they're doing okay and they're stable until they're not, which means they start to have more trouble breathing and they start to go on a ventilator, and then they go into renal failure, and then basically they have complications, including, bleeding, intracranial bleeding. So it is a virus that we still really don't understand all the effects.
So we just ended up dealing with a lot of the ICU situations in the early time of the COVID, and there was less people who survived from that situation. More people passed away. So to be honest, we don't talk about it, but since we talked about this particular, she was our first patient. And
well, to me, my story always used to be about them. They were doing well until they weren't. Because many of them were really felt to have been doing well, and they were stable, their vital signs were stable, and then one day they weren't.
Yep. So I believe there was a question asked, and actually Dr. Ortel already answered. Do you want to just bring it up, Dr. Ortel, and because about TOFs, rogue protein?
Yes, this is Dr. Ortel, and when you're looking at that post-viral syndrome and the cytokine storms and what's going on in the brain, there's the taus, there's the amyloid buildup, there's interleukin-2 and interleukin-7, granulocyte stimulating factor, interferon gamma, inducible protein 10, just tumor necrosis alpha. There's just so many of these chemicals, and we're not able to get these proteins out of the brain, and that is causing a lot of problems. And it's causing it all over the body also.
Right. Anybody else have any questions regarding the topic of post-COVID syndrome or post-viral syndrome before we go on to like the PPE area? Because we jumped a little, but it made sense at that time.
Yeah, I just want to add something here very quick. We have 5 million cases reported. And according to the science, they say if it's 5 confirmed, the reality is that every 1 case you multiplied with 10. So that's mean we estimate that 50 million of people are infected with COVID-19, which just mean less than 20% of the whole population of the United States is being infected. And so we really don't have much information. I mean, just 20% of the whole United States. So we don't know what's going to happen to the 80%. And then if we see that most of the vulnerable people, which is old people, they're already being sheltered and isolated, so they're not even exposed. They have lots of friends of mine, they don't even go out. And so the real post-COVID-19, we will see it. Maybe they won't see the cases, it's not familiar. I mean, it's not common, but it's going to be common after 1 year, after we reach to the more than 60-70% of the population. Then you will see the COVID-19 become common in the hospital. So that's my ad here.
Yeah, and so Dr. Ortel also mentioned that it could be as high as 1 positive for every 70 cases. Yep, and that brings up the question of testing. This has been, we know people who've gotten testing left and right. They get anxious about this, that, every 2 weeks or so they get tested. Now, if you are a frontline worker or you're exposed to COVID situation, you do get tested based on your internal organization's policy, weekly or biweekly or whatever that process is. I put up a workflow for a patient testing guide for COVID. And to be honest, one of the things you have to realize is right now that PPE area, supply chain, that's the mask, the test kits, the gowns, the gloves, that's a big business. There's a lot of middle layers, vendors, there's points where you're paying 3-10 times price because there's such a shortage. That happened early in March, April. Now flooding of these, but you don't know if it's really FDA approved. There is an FDA a fast authorization for any of these new testing kits that follows these 3 types. There are 3 types of tests: molecular test, antigen test, antibody test. I'll go back to that. But here's a workflow from Texas Medical Association about, if you're trying to get the patient tested. When you order that, there is a fee that you get. It can be telehealth, outpatient. When the patient goes to get the test or the test kit is like about, I want to say $21 per test kit is what the reimbursement is average. So that's very minimal for that test kit. But they're being sold at a massive bulk, 10,000, 20,000, 1 million. And it's being created and sold from different countries, brought into the United States. So the quality in terms of, okay, out of this 10,000, 20% is getting a false positive, or 20 doesn't work. So those kind of area is still kind of Wild West, unknown. So you want to make sure you are careful about where you are sourcing your test and trying to make sure that you track your patients, the type of test you do designate your patient to or assign your patient to have. Dr. Grossman or Dr. Okasana, do you have any comments on the three types of tests, the molecular test, antigen test, and the antibody test?
Well, I mean, there's no test that's 100% accurate. All right, that doesn't exist. But unfortunately, many of the tests being used really were pushed out. And there really wasn't that much, I'd say, investigation about the quality. And some of it was the quality of the test itself, but some of it was the quality of the labs and the people performing the test. So there still is, at this point, a lot of false negatives and false positives, and that makes the situation pretty muddy. And we just heard it with a governor. Was it the governor of Ohio that was supposed to meet with the president? And it was a whole big deal because he tested negative, but then he went home and he was retested by not the rapid test, but by a more, test that's used more often and takes longer, and he tested negative. So that makes me think that a lot of our testing is not where it should be. And this is for the virus. And so people are getting false information. I mean, I'm most worried about false negatives because then these people think, oh, I'm okay. I don't have to quarantine. I could go out in public and I'm all right. And they're not, and they're spreading the virus. And that's a really dangerous thing. In terms of the antibody tests, those tests also aren't really as accurate as they should be. And number two, we don't know the true significance of these antibodies. Are they protective? We don't know. How long do they last? We don't know. So basically, the only thing I would say is if I, come across a test and it's IgG positive, I'll say, you had the virus and you seem to have antibodies against the virus. But I would never tell them they're protected because we don't know. So all these tests, to me, are very nebulous. But I do think the viral testing is very important because no matter what, we could do contact tracing. And assuming that it's somewhat accurate, we at least could get those people who our index patient was in contact with and put them on quarantine, and that will stop the spread of this virus.
Yeah, just to kind of piggyback a little bit on Dr. Grossman's conversation here. I mean, definitely we utilize, the molecular test and the antigen test. The antigen test tends to be a more rapid test, so usually we try to go in. Usually for the antigen test, as rightly said here, positive tests are highly accurate. So, if you get, it's kind of like when we do the rapid, you get a positive, you're like, okay, fine, we're going to trust the positive. If you get a negative, you can't be very certain about the negative, quite honestly. So that is definitely something to kind of have in mind. And we usually with the antigen test, if we get a negative, we sometimes would also try to do a molecular test, at least in the hospital setting, to just really make sure. I do think a lot of people do try to kind of do more molecular tests though. Just because we just feel it's just more reliable. And, so we're not, because, sometimes with the antigen test, you get a positive, but you're still kind of like, if you're positive, you're done. If you get a negative, you're kind of not done. So
that's
you're kind of like, oh, great. So now you have to kind of go further. So that's one thing to think. I would say about the antibody test, I definitely have a lot of conversations with a lot of patients about the antibody test, and I think it's a lot of confusion because one, there's this assumption that your body, if you have this virus, you're going to make antibodies. 1, 2, the antibodies are going to stay around for a while, and none of these things are have been very much proven. I think, because there are definitely people who seem to have had coronavirus, but then had no antibodies to be found, which we don't know. Is like, were the antibodies just very fleeting, or did you make antibodies at all? And so I think it's just in all of these tests, I think the antibody is the most dubious one of all, because
Well, I agree. And remember, we have cellular immunity also. And cellular immunity plays a role in this virus. So therefore, your antibody titer could be very low. But if you have a good T cell response, well, then you're actually protected. Whereas antibodies just aren't giving you the whole story.
Absolutely. I mean, and I really caution. I have had a couple of patients who said, well, they want, when I think this was when we weren't testing everybody, and people were like, well, I want to make sure I really had COVID. I'm like, well, it's going to be very difficult for us to really ascertain, because if we get the antibody test, if it's positive, if it's positive, I guess we could really kind of say, okay, fine. But if it's negative, that does not really mean you didn't have it. And so it's really, it's kind of like, well, I'm not too sure why to do it. So it's, it is definitely a catch. It's a bit of a catch-22. The antibody
It is,
test.
especially since most of the patients want to know if they're protected against it. They want to know, hey, do I have the shield? I could walk out there and I have to worry because I had it, and I don't have to worry about getting it again. And we don't know.
Right. I mean, but truthfully, it's probably better. We just tell people, you know what? No, just don't do that. So yeah.
So then I want to just kind of address this in a very things that's being try to do in the industry, and that may or may not work is there have been ideas about a passport or a card or an app that vets you, saying, oh, you were tested, you were negative. But you were tested and you're negative only as of the date that you were tested and negative. Any day after that, you are still potentially exposed to and could have COVID. So that kind of identification or some sort of card that says, it's like your immunization card, but immunization card is different than a testing card. Then there's this thing called antibody, possibly a passport or something that says, oh, you had COVID already, so you're kind of, the shield, you got the shield, you're protected. Now there's two ways that it cannot be true, because, and Dr. Grossman, if you don't mind taking that one, the way it is mutation. Second is you may not still have immunity for the short.
Well, again, it's, it comes down to a few things. Yes, I have antibodies, but they may not be protective. They may not be neutralizing antibodies. They may be just random antibodies. I mean, HIV was very, very good at making just random antibody. You did have a lot of antibody, but it was a neutralizing antibody. And then since this virus mutates so quickly, yes, you may have great immunity to the strain that you had, but guess what? Now we have a new strain circulating, and you now have no immunity, even though you think you're immune. So it's a very complex story.
Yeah, but let's talk relatively here. If we say that we are using antibodies from recovered patients of COVID-19 to neutralize and heal and help to heal the people who are sick, so we cannot say for sure that there's no protection. No.
You see, again, what I'm saying is that, yes, I believe plasma antibodies work. But what we're talking about is antibodies going on as being protective to you, like as prophylaxis, really. In terms of using them as prophylaxis, it may be a different story.
No,
I mean, there's one thing about getting you better. It's another thing about protecting you, let's say 3 months down the road.
But I'm not talking about prophylaxis here. I'm talking about right now what they're using it, not for prophylaxis.
No. And again, but the people who are getting the testing generally don't have the disease, or aren't symptomatic. They want to know whether they're protected, because they've gotten over the disease. They want to know if they have protection, and you can't really tell them that.
Yeah, you cannot tell them that that's true, but still having the antibody is better than not having an antibody.
Well, no, I'm not. I think, look,
Right.
having antibody is good, but when you have a patient coming in wanting an antibody test, they don't want that test to find out, wow, you're lucky, you have neutralizing antibody. They want to find out, well, 3 months from now, am I safe? And you see, you can't tell them that. And that's where what your expectations are different from what their expectations are.
Correct.
I think that's fair. That's a fair point, because the general public, I think we as people in the field and scientists and medical professionals, I think we could have that nuance, the nuance to kind of say what certain things are. But I think the public, when they're hearing antibody tests, they're hearing, oh, I'm going to be immune. And I think that's where we have to really be cautious about giving them this results. And we're like, okay, yeah, you have antibodies, but what does that really mean? And we cannot tell you that these antibodies are protective. I mean, I think that's unfortunately situation.
Well, we can say those antibodies are protective, but we don't know it's going to last or not. So because you have to give some sort of meaning of why is positive and why they're using it to help patients who are sick. So you can say you have the antibodies, which helps you to protect you the virus, but we don't know it's effective or it stays longer.
Fair.
So we cannot ensure that. I think that kind of thing gives them an idea that, okay, we understand, that this is antibodies. It definitely helped, but we don't know it's going to be permanent or effective for a long time.
But I think there is so much disappointment when people find out that even, the actor, Tom Hanks, he and his wife had the virus, and he was very disappointed to find out the information we're talking about, which means that he may have no protection. Yes, he mounted a good immune response, and that's good news, but now when he found out, that doesn't mean that you're really protected against the virus. And that's, I think, what people want. The information people want to know is now we don't have to worry anymore. We have protection. It's like I got my immunization against it, and I could go off with my life and not have to worry.
Yeah. So we had a comment here. I just wanted to address. So would it be very, very difficult to do a T-cell test alongside of COVID testing?
Would it be difficult to do a T-cell test? Again, if there were labs that were performing the T-cell test regularly, I'd say no. But at this point now, the T-cell test is not being performed very often, and they're not even sure what T-cell population you really have to study.
Right, absolutely. There are a couple of T-cells, of course. So
yeah, there are a lot of T-cell populations, and they're not sure which one is the right one. So at this point now, it's being done for, research purposes.
Correct. And the last piece of the comment was something that I will address, which is also even the passport was done with blockchain technology, which is likely the only way to do this on a grand scale, which is the basis for cryptocurrency, can be hacked. It's imperfect and highly suspect. It is and it isn't. A lot of the supply chain pieces are going into the blockchain area. And we do feel that there is an early layer of blockchain in the immune vaccination area that's already out there that could be adapted. But it has to be a centralized process. It cannot be a private agency or private company who's doing this, because it is the total population. It cannot go into different silos. So for that reason, we notice that there's a lot of companies, not just in the United States, in Europe and other parts of the world, coming up with the passport, QRG code. Everything is in the crypto wallet, crypto-based in blockchain. Even though in idea-wise, it's great, unfortunately, what you're saying is you're asking people to put water in when there's like 2 holes there, but it's not visible. That's what it's doing, because it is not going to be effective in doing a passport or a wallet. And you have to think about it in the sense, what would you be able to give anybody a passport or wallet against flu forever, every year? If you had flu this year, unlike coronavirus, which is every 3 months or so, the mutation and the new strain we're seeing popping up 3 to 4 months. the flu is every year. So there's a bigger timeline. You took flu shot, vaccine, you had flu this year, you have the same risk of having it next year. You have a new blend of potential viruses that they inactivate and give you as a vaccine that could protect you, but you could still get the flu. So the coronavirus and the COVID situation is like 5 to 10 times worse than that situation, and it's more convoluted because of the gap in timeline. It is not a year thing, it is every 3 to 4 months. So in 1 year, you potentially need to go through every potential virus every 3 months, a new vaccine or something. I don't know if that's sustainable or realistic. That's one way of looking at it, but the passport, maybe every 3 months if you had a shot or something, that's possible. So I just wanted to say that. Blockchain is my kind of thing too. Sorry about the background, kids. So the PCR, the more detail from the FDA about what is PCR, what is an antigen test, what is serology, and every antibody test, you need a certain FDA emergency use. And I truly don't understand why FDA has so many emergency use approval thing going on for some things that's actually normal. I still am, wondering about the convalescent plasma. And this we had dealt with in early mid-March when that particular patient was in the ICU before they even put out the policy, emergency use policy on March 24th. Why do you need a permission for something that's been normally done 20 years ago for decades? As long as you build out a policy for people to use it and have a standardization. Why do you need, but it's just a question, I'm not sure, there might be safety measures, but it delays everything, there's a bottleneck. We send the form to the ICU attending and sends it back to me. Can you explain how to walk me through this, completing this form that I need to take it to the FDA that will have a 4-hour turnaround or 8-hour?
Yeah, they were very convoluted. It really took a long time to fill them out. It adds so much information that was unnecessary.
It's an interesting layer as you get more involved into the COVID fight, I guess, frontline fight. You get exposed to a lot of inefficiencies, a lot of red tape, I want to call it, and misuse of funds and misuse of resources. It's just commonly we're seeing, and it is, as you know, it's an inefficient system in this country, broken system. There's a lot of things that goes on that doesn't make sense. And hence why we are in this problem of having 5 million people tested positive for COVID and having this many people die when other countries were able to bring it down better. Because other interests are taking priority versus just doing the right thing the right way the first time. Wanted to talk about, if we have time, a little bit about the mask. I know we are going up until 8:15. I know I kind of scheduled it to 8:15. So if you still have time, we can go up to 8:15. Dr. Ortel, you actually did a lot of digging into the mask. If you want to mention anything, feel free to it.
Okay, so the big take-home point is any cloth mask, unless you do something extra to it, you're not going to get a lot of protection just from the mask. However, all of the studies looking at 80% of the population being masked, you find out that that reduces your viral load exposure. And if you come across and have a small viral load because the person had a mask on and you had a mask on, then you're more likely to be an asymptomatic COVID person. You'll have some shedding, but your body's going to get rid of it faster, and you may not even realize that you were sick. So we know that on the front line, people who weren't wearing proper PEEs because they weren't available versus the general population, frontline healthcare workers were getting infected at a rate of 2,700 per 100,000, where the general population was getting infected at a rate of 240 per 100,000. So frontline healthcare workers, with or without coverage, were getting infected 3 times at a rate 3 times as high. So I spent an hour and a half doing a deep dive into all this. Whether you use a shield, whether you use a mask, really you need, as long as both are using a mask, the shield may or may not give you a little bit of extra protection, especially in the dental office for the dental workers. But having a cloth PPE, you can usually add Kleenex, paper towel. There's a lot of data coming out of Hong Kong very early on how to make your cloth mask even a better barrier for yourself. But if everyone was wearing a mask and doing social distancing, you would probably get, according to the models and some of the data that's coming out, you would reduce your load. And that's what we're looking for.
Correct. And I wanted to say, you want to caution people who you are seeing, the best is, there's this fabric, it's almost like a mesh material that's supposed to cool you down when you're wet. Now they made a little face covering of it, no double thickness, just single layer. It is not, but they won't call it a mask. They call it face covering. So there's a loophole. So you need to think about what is happening now. We have the misleading on the PPE, the testing kits. I don't want to say misleading. It is, wild west of inaccuracy and variations, because everything is not standardized in the sense of, because of the need, people are getting, able to sell and manufacture things and sell it under these names. You get an approval 6 months ago, and that's so good now. You made it a month ago, quality testing, you don't know what happened. Same thing with the mask. Now they call it face covering, so it doesn't apply in the word mask. It's a face covering, and it is actually a cooling material, or it could be copper infused material. There's like all these things. So you have to be very careful about that, because that is not giving you enough protection. You need a few layers or thickness into that. You can even buy this, what I find is a carbon insert into mask. They make that. And that has good protection because it's fabric. You can take it out, the carbon insert, and wash the fabric material and put it back. Dr. Ortel's suggestion about the tissue, very excellent one, because that's very, you can do it at home and make it. And you can recommend it to any patients you have, so that if they are struggling, one of the things that we run into is some of the home health aides and parents struggling to find the mask or buy the mask. So you can make it with your own tools available at home.
So would you take the vaccine of Russia or not?
What is
No.
it?
We'll wait after the
Russian vaccine.
Oh, yes.
Putin approved Russian vaccine.
Before we jump into that, we just want to mention this. This is a Washington Hospital paper that they posted about the eye coverage. There's different types of coverages, obviously, but one of the other things you need to be mindful of is you have to cover your eyes when you go out. So please make sure that your patients or your family members, loved ones, do wear sunglasses, something to cover their eyes. Then we go into the vaccine. Latest is, whoever wants to jump into the Russia story, go ahead.
No, I just want to mention that Russian vaccine approved by Putin, it's political, and really it's Russian is competing with the United States, because the United States is making money out of the vaccine worldwide, and that's why Putin is jumping in. Anything that American is in the frontier, they're trying to crack that and be their frontier. So, but I don't trust the Russian vaccine. I don't think they passed through the right clinical trials and the right data.
Hey, I thought
What is this vaccine? How is it made? I mean, you know, he says he has a Russian vaccine. Is it our vaccine speaking Russian? I mean, he doesn't say what it is.
So Dr. Grossman just brought this up earlier when we were trying to prep for it. So I did a quick scan on the Russian translated to English major publications out there, news medias. Nothing. Russian side is silent. Only information about this Russian vaccine is available outside of Russia, not inside Russia. Just letting you know.
No, he said Putin. He said he gave it to his daughter.
Yeah,
You know
but
that?
he's
Must have
not
been his
telling
favorite
Russian
daughter.
people that.
It was his favorite daughter.
Hey.
Oh gosh. I mean, well, okay, but jokes aside, I think with everything, I guess it's fair to kind of be excited about it. Of course, yes, they kind of did fast track it, which I guess is what a couple of other places are doing. They're fast tracking it. I think hey, they said they're starting their phase 3 trials this week. Well, I mean, let's see the phase 3 trials, I guess, and take it from there. But yeah, I wouldn't be taking it.
Well, the United States needs to take this Russian vaccine and try it and test it whether it's working or not. That's how it's supposed to be.
Absolutely, I would agree with that. I mean, yeah, then you try to get some. Russia is supposed to be our friend nowadays, no? I mean,
No, I don't think so. No, I think you're thinking of a different Russia.
Putin is trying to play both sides. He's also trying to be nice to China because China is closer to him. I believe he has a border with China, so there are things
he
going
does.
on.
he does, yeah.
So he is trying to build out that relationship. So he's not trying to be too friendly with the United States, but he's not being negative with the United States either. He's keeping all the information super quiet within Russia, but they already knew there were Chinese-Russian border. Chinese people were coming in. They did have to close the border. There were stories about all this. And then it's only about a month or two ago, there were doctors from Russia posting online about how horrible it is and what is going on in the ICUs and the hospitals. To be honest, I took a COVID break in terms of this kind of mentally taxing stories, so I haven't looked at it latest ones. I'm sure it's not pleasant, but Russia is number 4 right now, so more higher is Brazil and India. After that, Russia is 800,000 total COVID. I don't know what is their total population versus that, so it will be interesting. And I don't know how much. So there are some rumors about the whole in China, the major shutdown, Chinese, oh God, I can't remember which city and all that's China. Now let me think about it. It's not, I think it's Shanghai, could be Shanghai, shutdowns and talk about things happening, but we don't know. Information about all that is very quiet. Not a lot of things are coming up.
Well, the reality is that this vaccine business is $1 trillion business. So it's a big, big business. And I think Russia is fast tracking it to get that money instead of the United States taking it. So that's what it is. It's more competition about money and who's going to get those $1 trillion. And of course, whoever do the first and it's effective are the one who's going to get it. So I think it's a competition between the United States and Russia and getting those trillions of dollars.
Good. It is going to be $1 trillion or more, business. So somebody, William Robinson already mentioned about asking about the $5 saliva tests that Stanford came out with. I would love to see that because Rutgers lab already have a home saliva test that they're trying to get through the approval process right now. So they already have it. That is also, I don't know the cost of it, but that is there. So we're going into the next session, which is next race is home testing. People just get a test and test it. It's going to be like checking your blood sugar. I check my blood sugar every day, checking your blood sugar. It could be like that because you never know. And that would be a $5 cost. It could go down to $1 cost if they can bring it in a massive, scale it up. And the United States is doing everything it can to do manufacturing inside this country. So we'll see it. Will be something that will be cool. what about any other testing that's coming up? Because in the last few sessions, we did cover about the vaccines coming up with the one antibody or the two different ones, inactivated viruses, then the 5 that's out of Columbia and your Presbyterian Cornell guys. I'm not sure if anybody else has anything else to add about that. Let me know, Dr. G.
No, I don't think. Everything is still new and being, worked on. Nothing definitive out there.
Okay. So anybody else have any questions? Because or comments, we'll open it up for that now because we are done on this one. I don't think we have any other topic to cover. I really appreciate, William, if you can send me the link. I would like to see it too for the Stanford $5 saliva test. Every one of them have to be approved by the insurance. Otherwise, the insurance will not pay for it. Obviously, the COVID fast tracking approval will allow insurance to pay for it. And right now, COVID testing kit is $21 per testing kit. That's the reimbursement. If Stanford charges $5, but the middle layer who actually administers it will be charging $21. That is the difference. And that's how this industry works. $21 is cheap. The markup is like 10 to 20 times on things. So it could be different. We'll see what happens. Anybody else have any questions, comments? So I would like to ask for some feedback. If you have any questions or comments, you can always send it to inquiry@Globex Health. We just try to make it simple. Next session is going to be session 7. We have several physicians who are practicing who have COVID treated and successfully treated hundreds of COVID patients as outpatient. Will be sharing their stories, and many are not mainstream, and they do use some of the alternative medicines or integrated medicine, so it's not always that mainstream 1 or 2 things out there. There are many things that work. Obviously, that China, they used traditional Chinese medicines. There's a whole research side to that. There's got at least about 200 different ingredients there actually now, or different situationals out of like 20 plus ingredients that they're doing clinical trials on traditional Chinese medicine. India has Ayurvedic. They have been using Ayurveda, turmeric, curcumin, all comes from India, that whole beer, and same from TCM. So you understand there's all these underlying principle, and they've been using it. So some of these physicians have that kind of blended knowledge, and they've been applying this to COVID. And we have asked for them to come and share some of them that they feel comfortable sharing. It should be next session. Everything is thrown off track for us because of last week. Many of us lost power. The hurricane, which turned into a tropical storm, but caused damage and power loss. So things are a little bit delayed on our end. So it could be next week or the week after. By session 10, we are bringing into a little more heavy IEEE, blockchain, genomics, some of these areas will be coming in, sharing that. So we're going to be doing some sessions in collaboration with IEEE. I chair the IEEE's blockchain in healthcare genomics task in a work group. So I'm bringing some people from that side to kind of bring in that area. So hopefully we'll have a bit more of that type of conversation. It will have some supply chain, how we are tracking. So if the patient has positive today, but in 3 months down the line, a positive in a different strain, that kind of tracking will be needed. And what did you use now, or what kind of symptoms are coming back from being treated with hydrochloroquine or whatever? We need to kind of do some post studies, so there are efforts being done. So we're going to bring some people who are working on different areas to talk about that. And if you have, and as the last session will be the people who first started our first session, which would be Dr. Grossman, Dr. Ortel, and Dr. Obesanya. So, and we'll close the loop and bring in some more of the genomics deeper dive into that area. So if you have any other questions, please let me know. Otherwise, thank you for coming and have a good night.